Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 34-year-old female who came to our ER with an alleged history of deliberate ingestion of rat kill poison, which was like 2 days prior to the admission to our hospital. She went to nearby hospitals and after that only came to our hospital, sir. So on initial assessment, the patient was conscious and oriented, and coming to the primary survey, the air was patent and there was no pooling of any secretions. In the breathing, air entry was bilaterally equal and saturation of 98% maintained in room air with a respiratory rate of 20 per minute. In the circulation, all peripheral pulses were palpable and the BP was 110/60 mmHg with a pulse rate of 68 per minute. In disability wise, GCS was full score and pupil was equally reacting. In the exposure wise, she was exposed and there was no, she was afebrile also. And coming to the adjuncts to the primary survey.
If this patient presented to you soon after ingestion, one patient is presenting to you with unknown substance soon after ingestion, what is the important thing you will look or you will do in E?
Exposure, we have to adequately expose the patient and we have to clean the patient, we have to decontaminate
the patient. Especially if it is an unknown object, it can very well be an organophosphorus, right?
Yeah.
So it can affect the healthcare professional also. So adequate decontamination should be done for all patients irrespective of the ingestion. Okay.
And here we took a VBG. VBG was showing no acid-base derangement and the bilirubin was also in the normal range with the creatinine also in the normal range. And the ECG was showing normal sinus rhythm. So we went ahead with the secondary survey. The history was she had a private fight with the family and followed by ingestion of rat kill poison, zinc phosphate 80%, approximately 20 gram, like 2 days before coming to our hospital, and she was then initially taken to a government hospital where gastric lavage was given, and then later on to another hospital and wherein which she was managed conservatively, and then later on admitted from there and came to our hospital for further management. There was no history of no complaints of abdominal pain, jaundice or altered sensorium, fever, melena, hematemesis or any other bleeding manifestation, and there was no any past history of jaundice or liver disorder for the patients. And initially we sent for the lab investigation here. She was stable and on the lab investigation, her CRP, there was no any actual count raise or total count raise. HB was on the lower side, like 11.4 with the total counts 3.59 and bilirubin of total 0.41 and direct of 0.14 and OTPT also 10 and PT INR was also in the normal range, INR of 1.08 with the APTT of 26 and creatinine also in the normal, urea of 8.8, creatinine of 0.38. And the electrolytes, coming to the electrolytes, potassium was little low of 2.9. Other than that, her electrolytes were also within normal.
Okay. Fine. So what is the examination finding? Anything examination will you look for? What will you look for in this examination?
So as patient here came with his alleged history of zinc phosphate intake. Examination wise, we have to look for any bleeding manifestation, coagulopathy features,
macro and micro coagulopathy features we can look for. Any ecchymotic patches, gum bleeds. Conjunctival hemorrhages, all these things we can look for. Okay, what else?
Then we can also
what are the main organs which is affected by zinc phosphate?
Liver coagulopathy and liver failure.
So it affects liver. So it happens hepatitis, right? Toxic hepatitis is the byproduct. So in examination, what will you look for?
examination we can look for hepatomegaly.
Hepatomegaly, tenderness, you can look for over there. What else? What other organ systems will be affected?
Then a patient, if at all, patient oral mucosa can be affected if any co-ingestion is with the same. Then
What is one of the most common co-injections patients take with zinc phosphate?
alcohol.
Alcohol. Usually patient can mix it with alcohol and take. Okay, what else?
Then we can also look for as it is rat poison. We can also go with an X-ray abdomen to look for any radiopaque substance like barium can be seen as radiopaque in X-rays.
Yeah, so rat poison, rodenticide poisoning doesn't mean it's only zinc phosphate or aluminum phosphate. It can be heavy metals, barium, arsenic, thallium, all these things can also be used. Very uncommon, but it can also be used. So there are different types of rodenticides, right? So one of the things is heavy metals and phosphine induced. Then you have superwarfarins, isn't it? Coagulopathy inducing agents. So identification of what type of rodenticide the patient is taken is utmost importance. Okay, what else? What other organ systems will you look for? Okay, let's come back. So this is a zinc phosphate ingestion. So how does zinc phosphate cause toxicity in the body?
So zinc phosphate after ingestion will phosphorus will change to phosphine, and this will cause toxicity.
Yeah. So there is something known as metallic phosphates and elemental phosphate. So elemental phosphate was notorious to cause toxicities earlier, very earlier, but the thing why it was very toxic was phosphorus was used in matchsticks to lightning. So yellow phosphorus was used. So yellow phosphorus is highly toxic form of elemental phosphorus. There are still 3% yellow phosphorus compositions made for rodenticide poisoning. So the elemental for 3% yellow phosphorus or yellow phosphorus in elemental form is highly absorbable and is readily transferred, made into phosphine gas. Even zinc phosphate, aluminum phosphate, everything has metallic phosphorus. It's not elemental, it's metallic. But even then, on contact with gastric acids, the mechanism that happens is phosphide is turned into phosphine gas. Phosphine gas is absorbed by the gastrointestinal tract into the bloodstream, which affects multiple organ system. So once phosphine gas is released and it's absorbed, it's very, very unlikely we can reverse its effects. Phosphine gas is very toxic. Now, if phosphine gas is produced and affected, what is the time duration we are looking at?
So we can have early and late type of ingestion and symptomatic manifestation. In early cases, we can like it within a duration of 6 hours itself. We can see cardiac arrhythmias and
so it depends upon two things. What is the type of ingestion that is taken and what is the quantity that is taken. So if it is elemental 3% elemental yellow phosphorus, then the amount of phosphine gas generated and the rapidity is much faster. So patients will develop features of toxicity much more earlier. Zinc phosphate, aluminum phosphate also causes phosphine gas production, but it is dependent on the amount consumed. So LD50 lethal dose 50 LD50 of elemental phosphorus, metallic phosphorus, sorry, no, not elemental, metallic phosphates, that is zinc and aluminum phosphate, comes around 500 mg. So unless that much is taken, the rapid onset of symptoms is not commonly seen. But phosphine gas is released and it is absorbed. It takes time for development of symptoms, but toxicity has already started. So as you told, toxicity can present as soon as 6 hours, and one of the most common toxicity that is shown is cardiac. So cardiac, what are the manifestations of phosphine gas in heart?
QTC prolongation.
Yes.
Then we can also have other arrhythmias.
Arrhythmia. What are the commonest arrhythmias that is caused? Fibrillation, flutter, and VTs. Okay. Fibrillation, VPCs, fibrillation, atrial fibrillation, atrial flutter, and VPCs are ventricular tachycardias are most common. Then, what else?
Then hypotension, circulatory shock.
There are two reasons for hypotension. One is how heart is affected. Heart's contraction is decreased. So, decreased cardiac contraction causes a component of cardiogenic shock. But phosphine gas also affects vascular vessels. Vessels as such is causing dilatory effect, causing vascular collapse. Refractory hypotension is one of the features of phosphine gas toxicity. So, patient will have vascular dilation caused hypotension, and a bit of cardiogenic shock will also be there. Refractory shock will be there. What else? Heart, blood vessels is over. Then what else?
Then patient can have electrolyte abnormalities like hypokalemia in zinc phosphate poisoning, and also in refractory cases hypomagnesemia, hypocalcemia can also occur.
Yes. So, multiple high electrolyte disturbances can happen, especially potassium, magnesium, phosphorus. These are the three things that can happen. Why these three are very important to be corrected in a zinc phosphate patient?
So,
zinc phosphate, aluminum phosphate, or 3% yellow phosphorus patients, ingested patient, why these three should be readily corrected?
For cardiac arrhythmia prevention.
Already patient is in risk of cardiac arrhythmia, and hypokalemia, hypomagnesemia, and hypophosphatemia can induce more cardiac arrhythmias. That is why readily correction of these are very much important. Okay, other than electrolytes, heart, vessels, electrolytes, what else can be affected?
Sugar changes,
hypoglycemia can be there. What else?
Then RFT, renal changes.
Yes. Kidney failure is one of the features of phosphine gas. So, acute kidney failure can be there. What else can be there? What other organ systems can affect? Liver can affect liver. So, coagulopathy. One thing is it can cause significant coagulopathy by itself, and it can also cause coagulopathy by affecting liver, causing acute hepatitis. So, acute hepatitis, coagulopathy. Then what about lungs?
Lungs, pulmonary hemorrhage.
Pulmonary hemorrhage and pulmonary edema causing acute respiratory distress can also be present. So, desaturation, severe tachypnea, pulmonary edema or pulmonary hemorrhage can also be caused by phosphine gas. So, it's a multi-organ involvement. So, patient's presentation can vary from a full-blown toxicity to various organ systems that is affected. So, we have to look for these things, but presentation of patient will vary according to the quantity that is taken and whether the amount of ingestion is readily absorbed or any intervention is done. Either patient vomited it out, self-emesis is done, or any healthcare treatment is done. So, if such a patient comes, acute presentation, this is already 48 hours is over. There is hardly anything we can do except supportive management and symptomatic management. Leave it. If the patient presented to us directly from the spot of ingestion, what and all management can you do for this patient?
Airway should be maintained with oxygenation support if needed. Along with it, breathing, but it will be the oxygenation support, and circulation. If circulatory collapse is there, to treat with IV fluids.
Yes. Well, let's think about a patient had accidental ingestion. Someone mixed rodenticide in food particles and was kept for rats, but unfortunately this patient consumed it. And they are presenting to you within 20 minutes, 30 minutes. How will you do? What and all will you do?
So after the ABC, then we have to do gastric lavage.
Yes. Gastric lavage. First decontamination.
Then gastric
lavage can be done.
Charcoal wash.
No.
And followed by...
So, you will give activated charcoal. How much activated charcoal will you give? 50 grams. 1 gram per kg to a maximum of 50 grams of activated charcoal can be given. First, you can give ഒരു gastric lavage if patient is presenting as soon as like 20 to 30 minutes. There are multiple gastric lavage modalities that is available, but scientifically speaking, gastric lavage as such is not proven to cause a improvement in patient conditions. There are gastric lavages that use coconut oil, they give potassium permanganate and all, but scientifically it is not proven to improve patients' mortality or morbidity. But gastric lavage can be considered if airway is patent and patient is cooperative, because once you try gastric lavage, one of the main complication that happens is emesis. So shouldn't be like patient vomited and aspirated. So that has to be taken care. And then you can give activated charcoal, 50 grams maximum you can give in an adult, or any patient who is less than 50 kg, 1 mg per kg you can give. Fine. Till what time will you give gastric lavage?
Maximum up to 6 hours.
The thing is, as we told, phosphate, elemental and metallic phosphate is readily converted to phosphine gas once in contact with gastric acids. So gastric lavage use is highly limited within the first few hours, that is 1 to 2 hours maximum of ingestion. After that, the phosphine gas might have already got released, and lavage as such will not have much of a activity. You can give activated charcoal to the patient, that is entirely different. But gastric lavage has not much of an improvement of patient condition after maximum first hour or maximum second hours. More than that, there is no point in giving gastric lavage. Okay, because especially because this is a very readily absorbed entity. If it was having a delayed absorption, we could have tried. This is readily absorbed. Okay, so you are given gastric lavage, you are given activated charcoal. What is the next step?
Then you have to look for any changes of you have to look for any bleeding changes, bleeding parameter changes. Or
yes, so you need a baseline investigations, right? So as we already told, it can affect the cardiac status. So you need a baseline ECG to identify what is the current QTC, what is the current rhythm. Is the patient having a risk of arrhythmia? Isn't it? So a known case of cardiac disorder, known case of patient on QTC prolongation drugs and all is risk factors for increased effects of toxin. So that we can do. A baseline coagulopathy panel has to be sent to identify whether patient already has coagulopathy or what is the current status to identify how much coagulopathy does develop. Then what else do you want to do?
Then you can look for electrolyte abnormalities.
Yes.
And then you can look for
early
GRBS.
corrections can be started.
GRBS can be looked for. Then RFT, LFT.
Baseline laboratory values can be sent to identify whether worsening is there. Then treatment wise, what and all you can offer to
treatment
the patient?
wise, we will be initially starting with supportive care only.
Yes.
IV fluids for if at all any hypotension or collapse is there, then
yes.
Later on we can start with N-acetylcysteine as if at all there is any changes in liver function.
Yes, as a hepatoprotective drug, we can give N-acetylcysteine, but it's not clinically proven to improve patient condition. But we can offer that since it doesn't have much of a contradictory status for the patient. We can give N-acetylcysteine. What else?
Then we'll monitor and wait.
Start N-acetylcysteine, how will you give? What is the dose? How do you give the N-acetylcysteine?
N-acetylcysteine can be given as initially a bolus dose followed by a continuous infusion, and can give 15 mg.
Yes. What is our institutional protocol? How much do we give?
600 mg initially, followed by 300 mg.
300 mg per hour infusion. So these kind of conditions in which we expect multi-organ dysfunction and especially hepatic toxicity with acute hepatitis and a possibility of permanent hepatic failure, every hospital should have their own protocols for hepatic failure patients. In this patient, we expect hepatic failure, right? Cardiac toxicity is something we symptomatically manage, and hepatic toxicity is something we have to manage. So every hospital should have their own protocols, and according to that protocols, N-acetylcysteine can be given. In our hospital, we give 600 mg stat and 300 mg per hour infusion. What else?
Then you had to look for any signs of any other breathing difficulty or other cardiac abnormalities, or how's the urine output, IO charting, everything has to be done.
Yes.
And we'll look for any features of acute liver failure, and if at all,
And supportive management.
supportive
can be
management.
good. So, how long do you think is the time duration in which zinc phosphate or aluminum phosphate poisoning will present to you? How duration of time after which it will present?
Duration,
It can present as early as 4 to 6 hours,
6 hours.
right? But how delayed can it present?
up to two days.
Yes, up to 48 to 72 hours it can present. Patient can be asymptomatic or with the mild gastrointestinal symptoms, nausea, vomiting, upper abdominal pain, and loose stools. They can present with these kind of symptoms up to first 24 to 48 hours. They can present without giving a proper history of alleged history of toxin ingestion, and we will be treating the patient like any gastroenteritis patients without a history of toxin. But on usually, if the poisoning is happened, phosphate gas is released usually by the 4th or 5th day. Our SGOT, SGPTs will start to rise and hepatitis will be very evident. So, a persistence of GI symptoms with elevating means hepatic enzymes should be thought about. A toxic component should be thought about in that condition. Okay. Anything else that we need to look into?
You have to watch for liver failure, and if at all liver failure is there, according to the Queen's College criteria, we'll have to go further about further management, including liver transplantation.
Okay, so basically supportive management, maintenance of coagulopathy, and if you have a GI surgery department who is willing to transplant for the patient and all, we can involve them in an early stage itself because we are expecting hepatic. Then it is supportive management, inotropic supports, dialysis supports, ventilatory supports for pulmonary conditions, isn't it? Okay. How was the patient?
Patient, after the initial, we started with N-acetylcysteine and other supportive care. She never went into any hypotensive state. Only her initial potassium was in the lower side. We corrected the potassium, and later on she was managed with the IV N-acetylcysteine infusion and supportive care, and she became better by the next 2 days, and she was later on discharged.
So, if a patient presents to you with alleged history of zinc phosphate poisoning, but after 24 hours or something, if patient is not producing any symptoms, how can you identify whether the patient had zinc phosphate exposure or not?
We had to send for toxicology samples, including initially we can go with a gastric sample along with the blood and urine sample. If she is coming later on, we will send with the blood and urine samples to look for any signs of any roadside panel. We will send for roadside panel to look which is the poisoning.
Not only gastric aspirate, blood and urine, you can send stool sample also because it's GI ingestion, no? So, phosphine gas once produced will be mixed with the stool and excreted also. So, phosphine gas presence in stools can also be used to identify whether phosphate toxicity is present or not. Okay. So, toxicology sample, taking toxicology sample for evaluation should also be kept in mind. Okay. So, patient was discharged home. Okay.